I want to make sure that we're understanding that it's just saying no to chronic opioids and why it may not be good medicine. I have a history of being anti-opioidist because back in the late 90s, all the way to 2006, 2007, 2008, when people were overprescribing opioids, I was a very vocal critic, both in lectures and in articles that I have written, and was considered a bit of a pariah by the pharmaceutical industry. Now the pendulum has swung awry. It has swung way too far in a very draconian fashion, particularly in the state of Washington, where I live and practice. And the bottom line is that opioids are fraught with a lot of problems. These problems include opioid-induced hyperalgesia, endocrinopathy, mood disorder, sleep apnea, and of course, overdose, diversion, death. However, at this point, we lack sufficient tools to treat all patients with chronic pain adequately, and accordingly, we have to consider that opioids should not be completely written out of the armamentaria of physicians who treat patients with pain, because certain select, well-identified patients can do well, particularly when there's no other option.
I do think that opiates have a role in the management of chronic pain. They certainly have a role in the management of end-of-life cancer pain. We're always going to have opiates in our armamentarium. They do work. And as Dr. Schatman pointed out, there are significant issues with comorbidity, but still when the day is done, they should be in our tool chest. I think the role of opiates needs to be readdressed, maybe. I do think, as Michael pointed out, that there was a big pendulum swing towards overprescribing, and now we're kind of going back in the opposite direction. We need to hit that sweet spot in the middle, and physicians have to take an active role and be an active participant in those decision-making processes. And if people are doing appropriate risk stratification and evaluation and appropriate patient monitoring, that would be a huge step in the right direction, and a uniformity of practice standards by all pain physicians.
I think that we can look at the state of Washington and see, again, what the impact of the very draconian Washington opioid law has been on people with chronic pain, even though the epidemiologic data are not yet all collected because of a lag time. What we have seen anecdotally, and we know is true, are two things. We're seeing a lot more suicides among patients with chronic pain, and we're also seeing an explosion of black tar heroin addiction, neither one of which is a particularly good thing.
Well, I would be maybe even a little stronger. I would say a world where physicians could not prescribe opiates would be hell. That would be hell, because you would have patients in severe pain and suffering, and I agree totally with Dr. Schatman. You just have a spike in the use of heroin and other substances. I mean, opiates are still our strongest analgesics, and they can be used safely and appropriately. It just has to be done with ongoing physician monitoring and proper patient selection. The comorbidities in part are a product of lack of appropriate physician monitoring. You can't be lazy doing this. It's hard work. And you have to be firm, and you have to have rules, and you have to make sure your patients keep their appointments, and you have to document functionality, you have to document pain control. It's doable, but that's what has to happen.
Dr. Carter brings up patient selection, and I can't place enough importance upon that. There seems to be a fixation in our society about how much, in Washington, the cutoff line is 120 milligrams morphine equivalent per day. And because we're so preoccupied with how much, we have lost a great deal of sight, very important sight, of to whom, because that's really the magical issue, or the most important question.
I agree.